Hello, I am Shelley Fold-Nasso, CEO of the National Coalition for Cancer Survivorship. Thank you very much for joining us today for our webinar on exercise oncology. This is part of our Survivorship Champions program, and we are grateful to you for joining us. And I want to give a shout out to the NCCS team for putting this together, and in particular, Veronica Peniotu, who manages this program. Thank you very much for organizing this webinar. We are delighted and honored today to have Dr. Kathryn Schmitz joining us. Dr. Schmitz is a leading researcher in exercise oncology, the use of exercise in cancer prevention, control, and survivorship. Dr. Schmitz, who has led many exercise trials and translated her work into clinical practice, has published more than 260 peer-reviewed scientific papers. I'm sure it's probably more than that, but that's the number that I saw on the website. I'm sure it's growing all of the time. As of October 1st, she is at the University of Pittsburgh, and she is the past president of the American College of Sports Medicine. Dr. Schmitz has made it her personal mission to use exercise for cancer prevention and recovery for all cancers. We're so grateful to you for joining us today, and I'm going to turn it over to you to share your presentation.
Thank you. Thank you so much for this invitation. I'm really honored to have the opportunity to give this talk, and I hope that it hits the mark for those who are viewing. So I'm going to try to share my screen, and Shelley, can you give me a thumbs up if you see my presentation in presentation mode? It's good? Yes? All right. So here we go. So the first thing to note on this slide is that, yes, indeed, I have moved. So those of you that know me know that I was formerly at Penn State. I am now, as of October 1st, at the University of Pittsburgh. And the other thing to note is that I have my social media links or handles on this first page. And that is in part a foreshadowing of something that I think is crucial in my talk, and that is, I think we need a paradigm shift, a cultural paradigm shift about exercise and cancer. And I don't think it's going to happen in the confines of peer-reviewed literature. I think we're going to need to take to the streets, as it were, and take to our phones in order to get the word out to the average person that there is a connection between exercise and cancer. So I ask you to join me there and join that voice. So the first thing to talk about is the evidence base, and I'll go over the evidence base fairly briefly in order for us to talk about what I think is really important, and that is, how do we make it happen for the average cancer patient and their caregiver? And so the first thing to say is that this is not something I cooked up in my garage this past weekend. So I had the great honor of editing a book called Exercise Oncology, and I got to write an opening chapter about the history of the field, and discovered that, in fact, the first example I could find in the peer-reviewed literature of study on exercise and cancer, relevant exercise and cancer, was from 1911. It was an epidemiologic study that showed that in the Industrial Revolution, people who were still more physically active in their occupations were less likely to develop cancer than those who were obese and sedentary. There also, throughout the 1930s, 40s, 50s, were occasional studies that were done by animal model researchers, all of which started with the idea of saying, oh, exercise is a stressor, and so exercise is going to cause cancer. So there was a series of papers actually out of the Wistar Institute that repeatedly showed that in fact exercise would reduce the risk of onset of cancer in a variety of different rodents and rodent cancer types. They kept being surprised, and these papers kept coming out about a decade apart with surprise in the voice of the authors that in fact exercise could be useful. The first human clinical trials happened in the late 1980s, led by nursing researchers Whittingham and McVicker at Ohio State University. And then Christine Friedenreich and Carrie Cornier published the first review on the topic of exercise and cancer in 1996. They identified 4 randomized controlled trials at that time and concluded, of course, that more research was needed. I published the first meta-analysis in this field in 2005, and we found 22 high-quality randomized controlled trials in the area and concluded that there was, in fact, benefit of exercise for people living with and beyond cancer The first ACSM roundtable on the topic of exercise and cancer was held in 2009, published in 2010. And at that time, if you were to have done a search of PubMed to look for the number of trials, you would have found close to 225 for exercise and cancer plus physical activity and cancer. And then between that and the second ACSM roundtable, which took place in 2018, there was a 281% increase in the number of randomized controlled trials. And that has only continued since. If you did a PubMed search now for exercise and cancer, say, limit it to humans and randomized controlled trials, you would get thousands of hits. So this is a field that's really come into its own over the past several decades. So that roundtable from ACSM from 2018 published 3 papers, and I'm just going to review what they said very, very briefly in order to give you an idea, an overview of the field. So exercise oncology starts with primary prevention, and the paper about primary prevention was capably led by Alpa Patel from the American Cancer Society. And this paper came out just about at the same time as the paper by Ann McTiernan from the Physical Activity Guidelines Advisory Committee Scientific Panel. And they both concluded just about the same thing, and that is that exercise is associated with reduced risk for 7 different common cancers on the order of 10 to 20% per cancer, including breast, endometrial, kidney, bladder, esophageal, stomach, and colon cancer. So the summary of the evidence base with regard to prevention of cancer itself in the pre-diagnosis phase is that physical activity reduces risk of 7 different cancers with a magnitude of risk reduction of 10 to 20%. But when Dr. Patel and her team did the review to look at post-diagnosis physical activity after a cancer diagnosis, we were able to see a 31 to 50% reduced risk of cancer-specific mortality, very specifically for breast, colon, and prostate cancers. So the prescription that is recommended by the American College of Sports Medicine, as well as the American Cancer Society for cancer primary prevention, as well as secondary prevention, is 150 minutes to 300 minutes a week of moderate intensity activity and twice weekly resistance exercise. If we move on then to the question of, does exercise change symptoms, side effects, cancer health-related outcomes other than the cancer itself? The paper that was written on this topic out of the ACSM roundtable was quite capably co-led by Kristen Campbell and Carrie Winter-Stone. And to really cut to the chase, I'm giving this somewhat short shrift in order to cover a lot of material today. What we were able to conclude, this was a systematic review of 16 cancer health-related outcomes listed on this slide. And the evidence review indicated strong evidence that exercise would have an effect on anxiety, depression, fatigue, health-related quality of life, breast cancer-related lymphedema, and physical function in patients with and beyond cancer, as well as moderate level evidence for bone health and sleep, and insufficient evidence for 8 other outcomes. Just as a little foreshadowing, there is a group that's doing an update on this. And so there is a publication that should be submitted for peer review soon that will update what we now know about these issues that were originally thought of as having insufficient evidence. So stay tuned for that, led by Dr. Kathleen Sturgeon. So the exercise guidelines during cancer treatment in order to improve symptoms and side effects in those 8 cancer health-related outcomes for which there was moderate to strong evidence, it's recommended that cancer patients perform 3 times a week of aerobic exercise, 30 minutes per session, and twice weekly resistance training exercise or strengthening exercise. There was a third paper that came out of the ACSM roundtable. I got to lead this one. This was quite the process, and you can see how long the list of authors is, and getting everybody on the same page about how we should go about implementing exercise oncology was quite the process. What we concluded in this particular paper was that we wanted to recommend the exercise as medicine approach, which has been used in primary prevention or primary care, not in the setting of cancer. So the recommendation here, and this is really seeing things at the 30,000-foot view, is that oncologists should assess their patients to see how much physical activity they're doing, both aerobic and resistance exercise, and then ask themselves a question: would this patient be safe exercising without medical supervision? And if their answer is yes, I believe that they would be, then the patient is seen to be ambulatory, probably has a functional status score, ECOG score of 0 to 2. At that point, you advise they do the amount of exercise recommended during cancer treatment, which I've just told you a moment ago, repeating it on this slide, and then refer them to the best available community program. On the other hand, if the patient is seen as not being capable of exercising on their own, or the clinician doesn't know and has no bandwidth to be able to triage and understand whether the patient should go, then the recommendation is that that person follow up with outpatient rehabilitation healthcare professionals for further evaluation, and then outpatient rehab professionals can decide what the most appropriate programming would be for that patient. The other thing that was a recognition at the very bottom of this slide is that this needs to happen probably more than once as people are going through their treatment, that it is not enough to do this just at the beginning of chemotherapy or in the middle of chemotherapy, but it needs to be done repeatedly. But as I said, that's really the view from 30,000 feet. And so the question then becomes, how do we actually actualize this? How do we make this happen in real life, in the lives of 1.7 million cancer patients diagnosed every year? So I've just shown you the guidelines, and one set of guidelines comes out of the American College of Sports Medicine, but there are also guidelines from the American Cancer Society. And just as of May 2022, there are now guidelines from the American Society of Clinical Oncology. And their voice is has a lot of gravitas. So we're hoping that the fact that ASCO has joined the chorus saying that exercise should be recommended during cancer treatment will be helpful for the implementation of exercise oncology. To summarize what the guidelines are, just to take everything that I've said so far and put it all on one slide, ACSM is the only organization out of the three major organizations that have issued American-based guidelines for exercise oncology that specify the dose of exercise that is recommended during treatment 3 times a week, 30 minutes of moderate intensity activity, aerobic activity, and then twice weekly resistance training. And ACS recommends exercise during treatment, but they're not specific. ASCO, again, recommends exercise, but is not specific to the amount. In the post-treatment timeframe, ACSM recommends both aerobic and resistance exercise. ACS recommends aerobic exercise, but is silent on the issue of resistance exercise. Don't think I want to take that as something that says that they don't want us to do resistance training exercise. They just were silent on it. And ASCO has not spoken on the post-treatment timeframe. So this is sort of a history of what's happened with the evidence base, and the evidence base in exercise oncology continues to grow. There are ongoing trials that are looking at exercise and cancer recurrence in colon cancer and prostate cancer. There is some beautiful, elegant science that's happening that's looking at dose finding and trying to understand what particular dose of exercise is necessary for a particular outcome in the setting of cancer patients undergoing treatment. There is a huge effort in the area of trying to understand the effects of exercise on chemotherapy treatment tolerance. The LEANER trial led by Melinda Irwin is recently completed and will be submitted for peer review very soon. And that was in breast cancer. The FORCE trial, which I co-led, but which was truly led by Betty Kahn, is in colon cancer and is complete and will be submitted for peer review soon again. And then the NCI has funded a large initiative called INICTO, which has 4 studies within it, one in older breast cancer patients that I lead, one in ovarian cancer patients that Melinda Irwin leads, one in colon cancer led by Justin Brown, and one in renal cancer, rectal cancer, and that one is led by Jessica Scott. And INICTO stands for Exercise and Nutrition Interventions for Cancer Treatment Outcomes. So this initiative is just getting started. I anticipate that we will have a definitive answer to the question of whether exercise can improve chemotherapy treatment tolerance in about 5 years. So there also is a growing amount of effort in health services research and implementation science, including my own attempts to discern how best to make exercise standard of care. That said, the evidence base is not all that we need. We need to do many things in order for us to be able to make exercise standard of care for the average cancer patient. So I'd like to pose a question to you all. What would happen if we treated chemo like the way that we treat exercise currently in the setting of oncology care? Now, I'm doing this for the purpose of an exercise. I do understand the difference between the curative care of chemotherapy and exercise being an adjuvant treatment. So, but just go with me for a moment for the sake of the exercise. So what we might say to people if we treated chemo like we treat exercise, well, there's evidence that chemo might help you. Here's a handout about it. You can call the YMCA and see if there are classes starting soon. If not, you might have to wait 12 to 15 weeks. The classes are only offered on Tuesdays at 7 o'clock. I hope that works for you. We'd like you to get some chemo. It's been shown to improve your survival in people with your type of cancer, and this handout will explain what to do. So hopefully by giving you these examples, you have some sense of the likelihood that people would get chemo if we were to give them these handouts or have programs that they have to arrive at 7 o'clock on Tuesday night is much lower. And so not surprisingly, when we look at who is doing exercise during and after their cancer treatment, it's very small percentages of our patients. All right, there we go. So what do we need to do? It's not just the evidence base. There's a lot for us to do in order for us to make exercise standard of care. And hopefully the evidence base is convincing to you that it is time for us to make exercise standard of care. So we're going to need policies. We're going to need policies and funding. We're going to need things that allow us to make this a sustainable activity, that this is not just something that the wealthy individuals who are in urban settings have capacity to pay for somebody to do exercise oncology with them. There's a health equity issue with the way that we currently practice exercise oncology, and I'll say more about that in a minute. We need clinical cancer care delivery implementation strategies to ensure appropriate referral. It is unacceptable to assume that oncologists and nurses treating oncology today have time to stop and have a 20-minute conversation about exercise. We need to set up the infrastructure so that we don't want to make those physicians and nurses wrong. We want to support them so that they can get their patients into appropriate exercise oncology programming. We need adequate programming. Right now, there is not adequate programming in every place that people receive cancer care. And the likelihood that you are going to have an opportunity to participate in an exercise oncology program is almost random at this point in the United States. We need an adequate workforce to deliver exercise oncology interventions, and I'll talk to you about how we're trying to develop that workforce now. And we need increased awareness of stakeholders regarding the value of exercise during and after cancer. And something that I'm not even getting to today, but I want to acknowledge is we need behavioral science, and we need to develop programs that help people to get past the sticky points behaviorally of getting them to be more physically active during and after their cancer treatment. So the Moving Through Cancer initiative of the American College of Sports Medicine is designed to try to address all of the points that I just had on my prior slide. And so I'm going to walk through each of these areas and tell you what we're up to. And I'm hoping that folks will want to help with trying to translate the evidence base into practice. So in the area of policy funding and sustainability, we obviously are interested in advocating for policies that support exercise oncology programming. And one of the ways that we've gone about trying to figure this out is we've started with a policy review. This has been submitted for peer review. And what we started with was a review of programs that we felt were exemplar programs that would help us to understand what needed to happen in order for those programs to become covered by third-party payers, by insurance, by Medicare, Medicaid, by CMS. So what did they do and what do those programs look like? And the three programs that we chose to review were the diabetes prevention program, supervised exercise training for peripheral arterial disease, and we looked at cancer rehabilitation in part because We wanted to start the process of the conversation that needs to be had about delineating the continuum, if you will, between people who need frank rehabilitation and people who are ready for community-based exercise. The major lessons learned coming out of our policy review was that we likely need to protocolize exercise oncology. We need this to be something that we can point to in the same way that the DPP is a particular number of sessions and a particular time period and is delivered by particular people who have particular training in particular settings, and there's training for those people to be able to deliver this. We need all of those elements of protocolization to be in place for exercise oncology. We also need to clarify who the coverage should be for. We're probably never going to be in a situation where we're going to have a personal trainer for all 1.7 million cancer patients who are diagnosed every year. That's just not tenable. So who is it that needs the help of an exercise oncology professional the most? And how do we get coverage for them? The second lesson learned was that coverage doesn't equal implementation. For all three of these programs, which all have third-party payer coverage, the proportion of patients who are eligible to receive these programs, who actually do receive these programs, is less than 10%. In some cases, less than 5%. So there is an awful lot of implementation science that needs to happen in order for us to make sure that we are not just getting coverage, but that we are implementing in a way that reaches people in an equitable fashion. We need to watch for a policy window. It occurred to us as we were reviewing what happened with DPP, what happened with supervised exercise training, with cancer rehabilitation. In all three cases, they were able to approach CMS at just the right moment when there was a political window for an openness to the possibility of some coverage for this new program that they were proposing. We do need clarification regarding the workforce. Right now, we say exercise oncology professional, and I'm doing wavy hands here in part because that's in fact what it is. We haven't delineated that that means that you have to have gone to a 4-year university program in exercise science, and then you have to do 8 weeks of this kind of training and this kind of certification. We haven't done that. We haven't codified what it means to be an exercise oncology professional. We need to do that. The other issue is that it has come to light based on this review that the outcomes that might be of particular interest for CMS to issue a national coverage determination may not have been studied yet. They may, we may have shot ourselves in the foot a little bit by focusing on all the symptoms as opposed to focusing on things that are associated with healthcare utilization or healthcare costs. And so it's possible that there is a new development in the way that we would do exercise oncology research in order for us to move this agenda forward. In addition to that, the Moving Through Cancer initiative has been working with national organizations to try to see if we can change policy with a little p. And what I mean by that is that I have been sitting on the National Accreditation Program for Breast Centers Standards Revision Committee for the past 2 years. And I'm delighted to say that the new standards, I thought they were actually adopted. I was on a call last night for NAPBC, and apparently it's going to be like in 2 weeks, they'll be adopted, will require breast centers to declare a plan for extra referrals in the setting of medical oncology and survivorship, which is great news. For the COC, there is a standard, Commission on Cancer. There is a standard on oncology rehabilitation, but as it is currently written, it does not point accredited sites towards exercise oncology as standard of care. It does point in a really, really promising direction. And so we're really hopeful to be able to work with the Commission on Cancer. Many cancer centers across the country are accredited by NAPBC and or COC. And so if they are required to meet these standards, then this is a policy with a little p way for us to move things forward. Then we need changes in our clinical cancer care delivery implementation strategies. We know that less than half of cancer patients are adequately active, and there are a whole host of reasons why that is the case. One of them is lack of referrals from clinicians. And so again, I'm extremely eager not to make the clinicians wrong. I understand that anytime you go into an oncology clinic, people seem to be moving very fast and getting a lot done. So but we need to create the infrastructure for them to be able to have a win here. In fact, when Dr. Jennifer Ligabell did a survey of the oncology workforce published in 2019, she asked the question, is it the responsibility of the treating physician to recommend weight loss and activity and nutrition? And nearly 79% of the respondents said yes, agreed or strongly agreed. Only a very small minority of the respondents said that they disagreed or strongly disagreed. And when you ask them, well, why aren't you? You know, because most of them are not, you know, the vast majority of them are not. Why not? There are many reasons, but there was one in particular that we found particularly compelling and a place where we could potentially try to make some progress. And that was the lack of training or experience about discussing these issues with patients. So we did a pilot study with a team from the UK that runs a course called Active Conversations. This is in collaboration with a large organization called Moving Medicine. I invite you to Google for Moving Medicine. Their website is a gas. Active Conversations is connected with them as well. So this is a practical evidence-based online learning course that was developed by clinicians for clinicians that teaches how to have quick, effective, positive conversations that encourage patients to do more activity. It is motivational interviewing based. This is a research-based approach to behavioral skills training that has been around for decades, frankly. So the course as it was designed and as we used it in the pilot study had 6 modules. There were 2 weeks between each module so that people could practice. There was a discussion board. You were required to then go in and say, well, I tried to talk to Mrs. Jones and she cried, or, well, I tried to talk to Mr. Smith and it didn't go so well and I'd like some, you know, support about this, or whatever your experience was, and people would reply and talk about their experiences. The course had a balance of reading and handouts and video examples. The video examples were hilarious. This was kind of a Monty Python group that had put this together. So it was highly entertaining. And the overall goal was really skill development. And the skills that were of particular interest were skills that are related to motivational interviewing. There are a number of them that are noted here. And I'll go over scaling in particular in just a moment. But I do want to talk about the expert trap for just a second, because I think it's one that we really all get into very quickly. And that is, we have this false impression that if we know that exercise is good for these patients, that if we simply tell them that they should be exercising, that they will magically go out and exercise. And that's the expert trap. You know, I know that exercise would be good for you for this following reason, and therefore you should. Unfortunately, that's not the way we shape behavior. So how do we shape behavior? One skill that we worked on through this course is called scaling. This is a way of exploring and building importance for the patient. So what you say is, I'm wondering, how important is it to you to become more physically active? Perhaps you could indicate on a scale of 0 to 10, where 0 is not at all important and 10 is very important. So let's assume they say 5. If they say 5, your answer then would be, well, you said 5, why 5 and why not a lower number? And then you wait and you listen to them say what is important about physical activity to them. And then you ask, well, what are some of the personal reasons you have for becoming more physically active? And therefore you're getting them to do self-talk that helps them to verify why it is that exercise is important to them. We did a pilot study with 11 clinicians. I'll point out that 3 of them were primary care docs. They were kind of our control group or our comparison group in order for us to understand how this was going to go in the specialty of oncology as opposed to primary care. It was just a small pilot, but we had surgeons, oncologists, radiation oncologists, and 2 nurse practitioners. And 10 of the 11 people who did this pilot said that they would change their practice as a result of the course. And there were 2 quotes coming out of the interviews that we did at the end of the study that I just think are really, really worth sharing. One is that she used the scaling questions now and not just for exercise, that asking key questions taught in the course has shortened, not lengthened, shortened my appointment times because the patient is more engaged and gets to the point quicker. And then one of the medical oncologists said that she previously told patients about exercise and it went in one ear and out the other because she was in the expert trap. The course changed how she talked about exercise. I spend more time finding out about information about the patient, letting patients bring out what's important to them. So the net promoter score for this course from the oncology clinicians averaged 9.4 out of 10. So they really liked the course and they felt that they were going to use this information in their practice. Interestingly, the primary care folks didn't like it as much. Primary care folks don't have as much time with their patients as oncology clinicians. So they said that they just simply didn't have the time to do what it was that was being recommended in the course. The feedback from the 11 clinicians that did this pilot has resulted in some changes in the active conversations course. Based on the pilot, there's a new foundations course that's half as long to give people a bite-sized version of the motivational interviewing techniques. We are working on getting US-based CME credits right now. You can get CME credits in Canada or in the UK, but not yet in the US. The course is currently available at the website that I am noting here on this slide. In addition to that, I have just learned that the American Cancer Society has a 0.5 CME course available free and online that is motivational interviewing based and isn't specific to physical activity, but would teach many of these same skills so that clinicians would have an easier time talking to their patients about becoming more physically active. And this one has CMEs and is US based. So the next item, the next issue that I had talked about was the need for programming, when and where it's needed. So the Moving Through Cancer Initiative has developed a program directory. We have 1,800 programs in the directory so far. We actually have just signed a contract with a staff person to help us to finish IDing programming across the United States. We're just over the moon, delighted that we're going to be able to finish this. And our goal is to complete identification of all of the exercise oncology programming across the US, to map that programming and to be able to identify the gaps and to be able to do geospatial analysis to understand whether there is a particular pattern of what those gaps look like. So I have a little map of the Northeast of the United States on the right side of this slide. And what you'll see is big blue dots, and those represent cities of 40,000 or more, and little orange dots, which are the exercise oncology programs that are found in these same areas. And what I want you to pay attention to are the blue dots that have no orange dots. And so we can absolutely show that there are, I think, about 5 on this slide, maybe 6 on this slide, where there are cities of 40,000 or more without any exercise oncology programming. What we hope to do with geospatial analysis as well is to see if there is a high enough density of programming, even in highly dense places like New York City. Could well be that there are a lot of programs there, but maybe not enough for the population that's there. So how does this programming work? Like how does this happen in practice? Well, there are basically 3 different exercise oncology practice models out there in the world that I am aware of. And if there are others that you know of, I'd love to hear from you and hear about them. But there's group fitness, the consultation model, the one-on-one model, and all of these can be done virtually. So the group fitness model, the examples of this would be Live Strong at the Y, which is an amazing program that's been going on since 2008. Dragon boat racing teams is a really popular one in places that have big rivers. Fit Steps for Life in Texas, and 2unstoppable.org, which is online but physically based in Northern Virginia. These are group fitness classes that are specifically for cancer patients and survivors, offered by professionals with specialty training in exercise oncology. And so there are some great advantages of the group fitness model. Brochure therapy becomes an option. When we do this, we can hand out the brochure or put the brochure in the waiting room and Bob's your uncle, you're done. You've done your job, right? This is then completely offloaded from the clinic. And so it's very attractive to busy clinicians who feel like this is, a great way to not have to say anything to their patients because they're busy talking about other things that are extremely important with their patients. The disadvantage is that we actually know that brochure therapy doesn't work. We know that the vast majority of people are going to ignore those brochures or throw out those brochures, that there's more needed than just handing people a brochure. The people who go based on the brochure would have found it even without the brochure, probably. There are also some potentially serious health equity issues with these programs based on the assumptions that they make with regard to time availability and transportation. Again, imagine only offering chemo at 4 o'clock on Tuesdays. That just doesn't work. So who is this serving? Who are these programs serving? Livestrong at the Y has served 68,000 survivors in the US after over a decade of service. Is that a lot? And what kind of service have they had? So that's an interesting number. I'd love to hear, understand more about what they've done with those 68,000 folks. The consultation model, Sammy Mansfield from Kansas has a company called Cancer Wellness for Life, which uses this consultation model. There was an organization called Sunflower Wellness, which is now part of the Maple Tree Cancer Alliance, that has followed the consultation model. And at Penn State, I started something called the One Group, which uses this model as well and is ongoing, even though I've left, now led by Katie Sturgeon. And this approach is an EMR-based referral for cancer patients into oncology professionals for assessment, prescription, some kind of minimally guided exercise, the amount of which is determined by the assessment. So if you have somebody who's 35, tennis pro, needs to know that it's safe to exercise, you send them on their way. If there's somebody who's got a lot of neuropathy and needs a lot of help to know how to exercise safely, then you spend more time with them. The referrals are made to appropriate community resources or home exercise according to what makes sense for the patient. It provides an opportunity for appropriate triage to PM&R or PT as needed and can be embedded directly into the cancer clinic, which means there's no need for referral to a separate location or additional appointments. Advantages of this are the, theoretically at least, better reach than the group fitness approach, a more personalized level of attention and personalized timing of sessions. It can address a lot of safety concerns because of the capacity of the exercise professional to coordinate with PT and PM&R. The fact that it's on the same location and no need for additional appointments. Telehealth, yes, it's great that it can be done over telehealth, but frankly, the group exercise can be done virtually as well. Disadvantages, it does require that you actually hire an exercise oncology professional to work in your oncology clinic setting. And thus you need to pay that person. It also means adding a referral to your electronic medical record, though that seemed to be a fairly simple thing to get done in several of the settings where I've seen this happen. So the third approach is one-on-one exercise oncology model. And my favorite example of this is Maple Tree Cancer Alliance, which is in, I think, actually more than 60 locations in the US and beyond at this point. And this is more of a cardiac rehabilitation type one-on-one assessment and personal training approach during and after treatment phase, as is cardiac rehabilitation for rehabilitation during treatment and then post-treatment. Where it's done really, really well, it's embedded directly within the cancer centers. It is also available in some settings as a virtual one-on-one telehealth program. One of the advantages of this is the likelihood of reaching patients. In smaller cities where Maple Tree has really gotten a strong foothold, they have hospitals where they have 65 to 70% of patients that are diagnosed at that hospital are seen by Maple Tree. So they're able to really embed themselves into cancer care. It is the model with the most personalized attention. It can also serve as a triage tool to PT and PM&R. It can be done on site or telehealth. And the other thing that has a huge advantage for this approach is this is how most of the research is done. Most of the research is done with a lot of in-person hand-holding and on-site work. And so it is, has more documented efficacy than the other approaches that I've mentioned. The downside is that it does require not just the staff, but now space on site, which is an additional ask, and some equipment and the method of referral. So coming down then to the workforce enhancement aspect of needing to make exercise standard of care, a primary focus in moving through cancer is to help prepare exercise professionals to work in oncology. So we have many thousands of exercise professionals in the United States, but a small proportion of them are prepared to work with oncology patients and survivors. So one of our early goals in moving through cancer was to survey exercise professionals regarding their exercise oncology knowledge. But what we realized before we did that survey was that we needed to agree on what that knowledge was. And as a result, we have started doing a Delphi project in order to come to agreement about, and I'll talk more about this Delphi project in a moment, but we wanted to come to some agreement about what people need to know in order to work in the space of exercise oncology. We also are interested in building training capacity by writing an undergraduate textbook that we hope will become the easy button for undergraduate kinesiology exercise science programs to offer a class in exercise oncology. It's called Essentials of Exercise Oncology. We have finished writing the first draft of the entire book, and it will hopefully come out in 2024. So the Delphi project that I mentioned has an aim to achieve expert consensus on knowledge, skills, and competencies for an exercise professional to deliver exercise programming to people with cancer as they undergo treatment. Recall that when I talked about policy, one of the things I said was that we needed to agree on what everybody needs to know in order for CMS to be able to say, well, who are these people that you're saying can deliver this program? We need to be able to have some kind of credentialing that is standardized in the same way that the DPP has credentialing that is standardized for people to deliver that program. So what we want is to ask, we're asking physical therapists, exercise trainers, researchers, and clinicians, what do people need to know if they were to be eligible for reimbursement for a third-party payer and working in exercise oncology? So we're hoping that this will lead to a revision of what is currently the American Cancer Society and American College of Sports Medicine Cancer Exercise Trainer certification to become a credential that better meets the needs of the field. Right now, there are only about 500 people in the country that have this certification. We want it to be easier to obtain, and that moves us closer to the workforce needs that we have in exercise oncology. So the last area that I'm going to talk about is the area of stakeholder awareness, empowerment, and engagement. And so right now we have a problem that if you ask the average person on the street, hey, your Aunt Betty has ovarian cancer, she's going through treatment, should she be exercising? They probably would say, no, she shouldn't, she should rest, right? And so we want to make sure that everybody living with cancer is aware of exercise benefits, at the very least that they have heard about this. And so we have developed a brochure, and we have funding from AbbVie in order to print these brochures, in order to put this brochure on our Moving Through Cancer website, in order to distribute postcards that would alert patients to the fact that this booklet exists so they can learn more about exercise and cancer. And we're eager to have partners in how to distribute this information. So if you have any ideas about that, please let me know. So our goal here is a social media campaign using the resources of both ACSM and the American Cancer Society in collaboration. We would love to have NCCS help in getting this done. And our goal then is to be able to measure improvements in levels of awareness among patients and providers. So our hope is that we actually plan to do a survey before we do this brochure distribution, and then come back in a few years in the same population and see if, in fact, they reflect that they know more about exercise and cancer. I would like to, before I finish, make sure that folks know that a couple of years ago, 5 years ago, my wife went through stage 3 squamous cell carcinoma diagnosis and treatment. And it was because of that that I decided that we needed to do more than the science, and that we needed to be communicating to the average patient. And so I decided to work with journalist Gabriel Miller and write a popular press book called Moving Through Cancer. This is written for people who are, this is written, Liz O'Riordan, some of you may know who that is. She's a breast surgeon and breast cancer advocate and breast cancer survivor in the UK. And she said to me in my interview with her for this book that there were days during treatment that she couldn't remember how to spell the word potato. And so I wrote this book for people who can't remember how to spell the word potato. This book is intended to be for the average patient who's currently, hearing the whooshing sound in their ear that goes with a new diagnosis or new treatment regimen that they're going to face. I'm gobsmacked. I just got word just yesterday that they've discounted the cost of the book for this month only to $2.99. Awesome. And the other thing to tell you about it is that if you buy the book and you go to the website associated with the book, you can sign up for a year free of what I call the Cancer Survivors Peloton, which is myvictory.com, which is an exercise library for patients living with and beyond cancer. I went the wrong way. I'm so sorry. So in summary, I think it's going to take more science, but I think it's going to take a whole lot more than science for us to be able to translate the evidence base into clinical practice, into standard of care, so that the average cancer patient understands that exercise is part of what they need to be doing to care for themselves as they go through their treatment and beyond. It's going to take changes in policies. It's going to take programs where they're needed, when they're needed. It's going to take implementation science. It's going to take a workforce development that we currently just simply do not have. It's going to take behavioral science, and it's going to take stakeholder engagement. And with that, I will finish with stating that I am exceedingly grateful for so many amazing colleagues around the world, all of the patients that have taken part in my studies over the past 20 years, and for all of my current funding, which is listed on this slide. And I think I'll stop sharing my slides now.
Thank you so much. That was wonderful. We have a lot of questions and I'm going to get to them. I'm glad you mentioned your book because I have it right here and I meant to mention it at the beginning. It's very good and that's great. $2.99. That's for a physical book, not a Kindle book. So that's great. It's really an excellent, it lays it out. I remember I heard you speak at ASCO this year in June, and you said, we wouldn't tell somebody to go get some chemotherapy. We would give them a specific prescription for chemotherapy, and we need to do the same for exercise. And this lays it out for people. So I thought it was excellent. And Veronica had alerted me to it. And I also wanted to mention a couple of stats from our survey that we have a webinar in 2 weeks where we're going to release the results of our 2022 State of Cancer Survivorship Survey. But we ask survivors, and these include people newly diagnosed, currently in treatment, living with metastatic cancer, and long-term survivors. And there were 1,400 in the national sample and about 670 in the NCCS sample. But we ask, what are their top concerns? And consistently every year, maintaining a healthy weight and getting enough exercise are among the top concerns, even though when we ask what you're talking about in your survivorship visits, they're not talking about it in their visits. But it was 61% of the respondents said maintaining a healthy weight was one of their top concerns, and 55% said getting enough exercise. So I think, the message is getting there to some degree. I mean, that more than half say getting enough exercise is a concern. So that's great. So I'm going to sort of take the liberty of combining a few questions, because there was one question about how much nutrition factors into this, and should you be talking about weight, or should you just be talking about exercise and nutrition, because weight is such a loaded topic and sometimes it turns people off. Yeah. And if you're just talking exercise and nutrition, you can still end up with benefits to weight without having that sort of loaded conversation.
Yeah, so I'm delighted to tell you that ASCO has really helped with this tremendously. So the ASCO guideline that came out in May was actually about exercise, nutrition, and weight management during treatment. And what they were able to conclude based on their review of the literature was that exercise should, they use the word should, okay? So should be recommended to people who are undergoing cancer treatment. What they concluded was that there was no evidence that any particular dietary pattern was more useful than another for people currently undergoing cancer treatment. I want to be clear that doesn't mean that there isn't something that's useful. It's that the science does not lead us to conclude that at this time. So I think that nutrition is behind exercise oncology with regard to the evidence base. And I would state, as a non-nutritionist, that it's because it's more complicated. When it comes to weight, they did not conclude that there was any evidence that there was value for people to be doing anything with their diet and exercise that would alter their weight during treatment. So I want to make sure that I'm reflecting that review really strongly. What I will also tell you is the story and the lived experience of most of the clinicians that I talk to about trying to get them to talk to their patients about exercise immediately think about weight and immediately talk to me about how difficult it is to talk about weight. And my favorite story about this was I gave a presentation to the External Advisory Board for the University of Pennsylvania Cancer Center years ago. And I finished talking, and somebody's hand shot up. It was a medical oncologist, very famous medical oncologist. And he said, you know, my wife and my daughter are really into fitness. So I started talking to my patients about exercise and weight control. And everybody I talked to cried. And so I'm never going to do it again. And I was like, oh my God. So I think, you know, and I had a very difficult time getting that oncologist to see, and I often have a difficult time getting oncologists and oncology clinicians to see that they need to separate the issues, you know, that, you know, talking about exercise or talking about nutrition is not the same thing as talking about weight. And then if somebody goes down that path, you can guide them back and say, I'm not talking about your weight. I'm not asking you to lose weight. I'm asking you to be active. We know, like we really know that exercise has its benefits in people who are obese, who do not change weight. So the physiologic effects that we can demonstrate from exercise in people living with and beyond cancer can be seen in people of all weights, regardless of weight change.
Well, and I think that the message for cancer survivors is that to decrease the risk of recurrence is so important there. And can you talk about, I mean, everybody hears the message, whether you're a cancer survivor or not, that exercise is important. And all of the studies show how important exercise is for cancer. Is it even more important for you once you have a cancer diagnosis to exercise than if you weren't a cancer survivor?
Yeah, that's a great question. I certainly feel like, you know, I have a fire under my wife as a, you know, survivor of a cancer that has a recurrence rate that's scary. So, you know, she's in the best shape of her life.
Mm-hmm.
So, but is it actually more important, or is it more, well, okay, so I don't know, but I don't actually know the answer to your question, but I'm gonna, you know, sort of surmise for a second that, you know, when we look at the relative merit of exercise for cancer prevention, it's on the order of 10 to 20%. Okay. And when we look at the comparisons of what can you do to reduce your risk of cancer, stopping drinking alcohol is more important than exercise. Okay. So put that in context with, wow, 30 to 50% reduced risk of cancer-specific mortality in breast, colon, and prostate cancer. And the only reason we don't have it for the others is because we don't have the data yet. I firmly believe that. You know, it's not a matter of that it doesn't work for the other cancers. It's that we just don't have the data. Those are hard studies to do. So I would say it's more important after the diagnosis.
Yeah, I had not heard that statistic that stopping drinking alcohol is even more important.
It is. If you look at the comparison of what's the most important thing you can do is quit smoking, right?
Right.
Okay. And then, you know, it's like, what proportion of cancers are caused by smoking, by this. And, you know, physical activity is on that list, but it's tiny compared to other things. Whereas if you look at what you can do to reduce your risk of cancer-specific mortality, exercise is way up there.
Okay, so can we talk about coverage? So
Yeah.
when you talk about coverage, you're talking about insurance coverage. Can you talk about any specific models you've seen that have worked to help provide this coverage for patients to remove that barrier to them participating?
Right. So what we have at this point is a patchwork quilt, and it is creates tremendous health inequities because the people who can afford to do these programs are the ones that are getting access to them. The places where these programs exist free of cost to the patient, there has generally been an investment on the part of the hospital foundation or the health system. I can tell you that Maple Tree, the founder of Maple Tree Cancer Alliance, Kathryn Wonders, has been remarkable at getting hospital foundations and health systems to buy in to this. But you know, most health systems are not currently supporting. I mean, at present, if you look across the NCI designated cancer centers, you're going to find a nutritionist in most of those cancer centers. You are not going to find an exercise oncology professional in most of those cancer centers. So coverage, what I'm getting at is, what would we need to do in order for the average cancer patient to have access to this programming at a low cost or no cost? And there are a variety of ways of doing that. The DPP approach is slightly different than the cancer rehabilitation approach, which is, you know, that's full on third-party payer coverage. I don't know what the right answer is. What I know is that it needs to happen, and I think we probably need a lot of health services work. I do see at least one comment on this particular issue. I can tell you that there is published evidence about healthcare utilization. Kathryn Wonders and I published one piece about the cost effectiveness of an exercise oncology program in early stage breast cancer patients. And that's in JCO clinical practice or oncology practice, OP. And there are a variety of others that are generally from other countries. There's not been a great deal of health services research on exercise oncology in the United States. And we need more. We need a lot more.
Okay, great. That's helpful. Thank you. And if you share the link to that study with us, we can post it with this website afterward. That would be great. COVID has impacted some exercise programs. What do you know about, like, sort of, are those returning back to in person, and how has COVID impacted the ability of people to do exercise that they?
Well, the good news is that COVID has broken wide open the idea of delivering this programming virtually. And, you know, actually, again, Kathryn Wonders has published a piece that shows that you can take a program that's generally done in person, put it online, and you get the same physiologic benefits. And so, you know, I know that the Zickham Center at Harvard has had tremendous influx of people who are using their online resources that include exercise classes. You know, I think that Livestrong, there were some questions about Livestrong in the mix, and Livestrong went online. Livestrong went virtual. So I don't know if it did that everywhere or, you know, just in certain places in the country, but it went virtual, and they actually had, you know, a tremendous response to that, and more people were willing to do it. I think that actually the virtual answer starts to answer some of the health equity issues that I was talking about, except for, you know, the rural people who don't have internet. So, you know, it creates a different problem. But I actually think that that COVID inadvertently helped us, because I think that there are more people who are willing to do things online and more people that are doing programming online. So I actually think it's been a good thing.
That's great. We have a lot more questions, but we are at 1 o'clock, so I don't want to take more of your time. And I'm really sorry we didn't get to more of the questions. I don't know. I knew you were looking at them. If there's any that you wanted to address just in a quick moment, or if not, we can just close out. But I'm sorry that we didn't get to all the questions, because there's some great questions. We can share the comments with you too, Dr. Schmitz.
I just wanted to say hello to Michelle Kirchner, who is doing amazing work in Ohio. And yes, there is an awful lot that is happening in metastatic disease. When I started in exercise oncology, the idea of doing exercise in the metastatic setting was no way. You couldn't touch those patients. And now we really are understanding that exercise can be tremendously helpful for clinical outcomes. So I'll just finish with that.
And we do have patients on this as well. And one asked, what about when you've lost weight? And you're trying to regain it? How do you incorporate exercise? That's something you can address.
Oh, resistance training to build muscle. Yeah.
Well, thank you so much for your time and your excellent work, and not just your research, but your advocacy about the importance of this for cancer patients and cancer survivors. And we look forward to continuing to work with you on some of these policy issues and getting the word out. So thank you so much for your time, and thank you to everyone for joining us and for your great questions. I'm sorry we didn't get to all of them.
Thank you. Thank you for the invitation.
Have a great day. Thanks, everybody.